Hi, everyone. This is Rupa again, Rupa Vemlapalli, and thanks for being here. So in our previous, the Women's Committee meeting, the committee members have requested a well-informed and national speaker who could discuss on the workplace violence. And then we are fortunate enough to have Ms. Karen Garvey, who is a Vice President of Safety and Clinical Risk Management at Parkland. And she's also the member of the member board of directors for American Society for Healthcare Risk Management. She has been in this role for the past 10 years at Parkland, and previously she worked at Cleveland Clinic. And we are very fortunate to have her today so that we can understand to how to handle and mitigate these unfortunate incidences, that are very uncomfortable for us to deal with. So without further ado, I hand over to Karen.
Great, thank you so much, and thank you for allowing me to be here. I just want to do a sound check to make sure that people can hear me okay. I think it was good. I think so. I'm just going to go ahead and jump into, what we're seeing in healthcare. I've worked in healthcare for a long time, and I'm sure like many of you, this has been around for a long time, but certainly this has escalated. What we have seen during and post-pandemic, I think it has really brought it to the public view. I have tend to call this you'll see it in one slide, the epidemic before the pandemic, but it's been behind the wall of silence. So the pandemic really pushed this out to external forces where things are now being reported, but the levels of aggression and the levels of violence, the harm that is happening, not just within the healthcare industry, but within society in general, it has just gotten to a point where people are leaving the professions and really are fearing for themselves. And so when I saw this last year of its rudeness here to stay, we're seeing it. We were heroes during the pandemic, but all of a sudden we have fallen off as being these evil individuals that, when we're trying to help people, it's the people that we're trying to help which are the ones that are the ones that are hurting us. So when we talk about safety and, being more in an ambulatory environment, I think many of you may be, it's not just the main hospital, but it is the ambulatory settings. And frankly, when we look at data within Parkland ourselves, being a public safety net organization, as we go to discharge patients from the system, and I'll talk about that in a little bit, it has been from the ambulatory clinic settings for the most part, although we do see the majority of our violence reports within the hospital per se. So as I said, the epidemic before the pandemic, these are certainly some of the headlines that have been out there. They have, at one point in time, they were coming out every single week. When you look at what nurses, the Emergency Nurses Association, the Emergency Medicine Physicians Association, they've been pushing the envelope for several years, and now are finally getting some backing. And as I was preparing for this presentation, I wasn't sure of where folks are located within the state. But Texas has been one of the states that has put a bill in place, and I'll talk a little bit about that later on, to actually protect healthcare workers. There's not two bills, but there's actually three. One of them is about just what hospitals and health systems are required to do as part of the Senate Bill 240. Senate Bill 840 is about the protecting them and what are the penalties towards the perpetrators, and then 915 is about signage and reporting to the Department of Public Health Services as well. So again, more, but these are more of where they are occurring in an ambulatory setting and not just within the hospitals. So there's plenty of information out there, which is driving a lot of why people want more mandated laws and rules to protect healthcare workers. So when you look at the Department of Labor Statistics, again, this is old data, and I have more current data. But even as you go back when this was not, it was there, but not as publicly prevalent as it is today. Really, healthcare workers have been almost 10 times more likely to be injured, whether it's from a non-fatal workplace violence injury than the general business and industry. So just looking at the information on the left-hand side, again, from the Department of Labor Statistics, but this actually was in one of the Sentinel event alerts from the Joint Commission. If you are an accredited hospital by the Joint Commission, they put this out there in 2018. Modern healthcare had kind of the same, but it's a different visual graph to show, when it comes to healthcare workers in general business and industry, we are more than 9 times higher than those individuals to be injured at work. So more current data looks at the incident rates for non-fatal assault and violent acts. And again, this is for only reported data. Many folks do not report the verbal assaults, the threats that they're subject to. We are seeing more and more of that and encouraging people to report more because we can't fix what we don't know. And so because of fear and shame of what people will think about them or even being bullied by peers, they many times won't report. But the actual social assistance, nursing care facilities, hospitals, and other private industry for healthcare or for healthcare overall, you do see the majority happening in the residential facilities. And it may be whether it is intentional, but you also may have folks that have dementia. And really, when you look at assaults, it's regardless of what their medical or behavioral or underlying condition is. We may be less apt to report somebody out of benevolence for somebody who has dementia that is slapping you as you're trying to give a medication versus somebody who's punching you and knowingly hitting you when they don't have that same underlying condition. So we're trying to get people to understand what violence actually is. What is an assault, whether it's verbal or physical? And then taking the time to report it, but that also takes time as well. And so when you look at the number of fatalities that actually occurred in from 2016 to 2020, there were 207 deaths related to healthcare. In 2020, when you look at healthcare and social assistance workers, there was 10.3 per 10,000 full-time equivalents related to injuries from assaults and violent acts by other persons. But nursing rates were almost 22%, were 22 of the 10,000. And then when you look at a recent study, the number of assaults have increased, and you're seeing more and more nursing and physician related studies where they're actually seeing the reports much higher than what is even reported here with a rate of 38 per 100 nurses per year. So again, Department of Labor Statistics information. In addition, this is again data from the Department of Bureau of Labor Statistics. So when you look at violence per the healthcare industry, again, hospitals are definitely the highest of where they are occurring. The general medical and surgical hospitals, and then when you look at the psychiatric and substance abuse hospitals and medical specialties, these are then how they actually fare out. Incident rates by industry. So again, all industry, and then looking at ambulatory healthcare services, nursing and residential care facilities. So that mirrors the slide I had previously. And again, hospitals are secondary to that. So this is, again, data that comes from the Bureau of Labor Statistics. And this is the most current data that they actually published in December, because it takes a while for them to be able to collate all the information across the US. So what are we doing nationally to actually protect healthcare workers? There has been a bill on the Hill, both bipartisan, that actually was out there and then fell off, but is now back on in legislation through Manchin in West Virginia and Rubio in Florida. So when you go to the airport and travel, you see the sign in the security line saying if you violate, do any of these things and step across the line, you're going to be fined. I think it's $1,300 and some odd dollars today. And oh, by the way, you could be thrown off the airline. And I can remember several years ago when they started to do that during COVID with all the disruption and inappropriate behavior that was happening within the airlines. I can remember being on a call with our CEO where he said, it's unfortunate that we can't do that because people have to have the ability to have health care. But the whole goal of the SAVE Act, and this has been really pushed by the American Hospital Association, is to provide funding to develop and to develop workplace violence prevention programs and provide the same legal protections that the TSA actually in airports also are subject to, the intimidation, the assaults that go on in an airport. And really, until I understood and read that, it's not the same thing, but they think about people that are missing flights or their flights are delayed, or, they're frustrated and people misbehave under certain circumstances. So the goal is to get monies out there to help protect healthcare workers. Also, from an accreditation perspective, again, this is from the Joint Commission. This is the Sentinel event alert that actually came out, but they actually published standards starting in January of 2022 that provide, and I have a slide on this, that actually provide 5 standards that leaders in healthcare organizations are required to do to protect their workforce. CMS came out in November of 22 and said basically the same thing. We want to make sure that our workforces are protected, and there's some elements that are out there. So as a leader in a healthcare organization, I know that we're coming up for our annual or triennial survey for the Joint Commission. We have a lot of information to be able to provide to the Joint Commission as well as leaders and our board members as to what are the numbers and what we're seeing, even though we have measures in place to protect our staff. So when you look at the Joint Commission standards as an example, they fall under 3 different standards I guess, service lines. So the environment of care, so we have to make sure that we're managing safety and security risks. And part of that is looking and doing risk assessments. Risk assessments in an ambulatory setting as to, do you have somebody that barriers for people to be able to get in? Are people scanned in? Many organizations are moving to weapons detection systems at the entrance points. How many entrance points do you have? And should you scale those down to actually have 1 or 2 that can be actually manned and where you have people actually checking people in and out? Those are some of the things that are required. And when you look at the other one about collecting information of conditions in the environment. So if you do have security risks and people get into your establishment that shouldn't be there, do you report those things and figure out how they got there? If they were able to access, physician workrooms, as an example, looking for maybe prescriptions for narcotic type things, verifying and reviewing and investigating those types of incidents becomes critically important for future protections that should be added in as part of a plan. Looking at the safety and security incidences. So in our organization, where I have a person who works underneath me or with me as a workforce safety manager, and he is mining all the workplace violence events that are coming through. But we also work collaboratively with our physical safety and security folks. We are not working in competition. We are working in collaboration to ensure that the safety of our staff first, patients second, visitors third. Yes, we have to make sure that everybody is safe, but we want to make sure that we're doing everything to ensure primarily that our employees are taken care of first, because if we don't have folks who are feeling safe in their environment, they're not going to be able to do the best work for the patients. The other one is for the human resources, is the learning component about ongoing training and education. So, what kind of training? And I think one of the questions when I asked to do this was, what are some of the things that you guys wanted to focus on? How do you de-escalate? Do you have de-escalation programs within your organization? I know I do. It's required for some of our areas that are more higher risk, such as our emergency department and our behavioral health areas. I have taken the de-escalation training myself. It gave me much more insight as to what our staff are having to deal with, but also I had to utilize it in a grocery store. It's something that can be utilized outside of even the hospital setting. So it's great information to know. And if you don't know if you have a program, call up your HR people in training and education and find out. And if you don't, you could probably find online training and education, but a lot of these don't do the justice without role play. You have to be able to manage, de-escalate, keep yourself from a distance. And some of it comes also down to, Psych 101 is always have your back to the door so you can escape. The other one is about leadership, and leadership looking to ensure that you have policies and procedures for reporting, but embracing people in reporting and not singling them out with fear of retribution. So those are also some of the things that are required by the standards if you are a Joint Commission accredited facility. So when it comes down to Texas legislation, knowing that Texas passed, it was House Bill 240, and then it moved to Senate Bill 240, where Texas now has a bill that went into effect on September 1 of 23, where all hospitals have to comply with certain measures by September 1 of 24. So when you look at what is required for Senate Bill 240, it is about having a committee. Certain individuals have to be on a committee. It's about having policies and procedures, a no retaliation policy, information that goes up to the board. If you're in an organization that has several facilities under one umbrella, you can have one committee. Practicing physicians at the bedside, practicing nurses at the bedside, a security individual. So there's a multitude of things that are required. And then somebody that has to be able to review the events and then investigate each one of them. When it comes to Senate Bill 840, it's about criminal penalties for those individuals that inflict harm upon any hospital personnel. It's not just clinicians. And this went from a misdemeanor to a third-degree felony. And this was based on the issue that had happened, the unfortunate shooting at the Dallas Methodist Hospital back in October, a year and a half ago. So the other component is that when you talk about a facility, so for Senate Bill 240, what is a facility defined as? If you are in an ambulatory setting, if you're in an ambulatory surgical type setting, it qualifies as a facility. It's not just a hospital per se. Any nursing facility licensed under Chapter 242 that employs at least 2 nurses, a mental health licensed facility in a freestanding emergency center. So these are all what's defined within the Senate Bill 240. When you look at Senate Bill 240, these are all the elements, and this was our gap analysis that we continue to keep an eye on of who is required to be on your committee. We have to have a workplace violence plan. Every organization in the state of Texas is now required to have a development plan, just like you may have an infection control plan, a risk management plan. You're now a disaster plan. You're now required to have a workplace violence plan by September 1 of this year. And it has to be developed by a multitude of folks. As I mentioned, policies and procedures, and then what are you doing to ensure that your interventions are evidence-based? So again, de-escalation, there's many types of de-escalation programs out there. We have a behavioral emergency response team that responds to de-escalating patients and aggression. And then we also have added agitation order sets within we've had them within our EPIC system, but people were not necessarily utilizing them. Data reports to the board, we present at least twice a year and more often as necessary. Annual training that's required for direct caregivers, and then the reporting of incidents and then a plan. So on the right is what we have had for our plan. This is our actual 2024 plan. And this is our 4th plan because I've been working on this since 2018 when the law was first being socialized, and then it fell off the docket during COVID and then came back forward. So we've been well ahead of the curve with getting some of these expectations in place. And so the other component that came out was there is required signage by House Bill 19, which says basically where you have mandated signage in your organization about HIPAA, there's just general signage. You have to provide information as to any employee, any physician that can actually report to the Department of Public Safety, any event in an anonymous way. We knew that this had come through because we had commented on the proposed bill before it actually went into law, but we never heard back until about a month ago that this was an expectation, and we were like, oh my gosh, we are not doing this. So we do have the signage ready to go, and again, this has to be posted English and Spanish within your organization in the employee-focused areas. Not out for patients, but and then this became the signage that we actually have that's going to be going up in those areas. So if this is basically a share because we were kind of behind the scenes on this one. So when it comes to violence, it's not just within the hospitals. Even as the final Senate bill came through of 240, they had at different versions of the bill did have the community setting and as part of the overall plan. In the final bill, they took it out. Now that doesn't mean that the clinics and ambulatory settings were written out, they weren't. But when you look at the community health workers, those that don't have any brick and mortar around them are highly vulnerable when you look at home care in the hospital at home. So we know that the ambulatory settings, because I think in the state of Texas, I'm not sure if the gun protection laws govern those, depending on how your clinic may be connected to your hospital or not. But people are still utilizing the signage that no weapons are allowed in the organization or in the building. Other types of services and why things are happening is because of the chemical substances, the abuse that people are looking for narcotics. We're looking also in some of the areas, neighborhood crimes. I know we're in our organization, we selected a couple of clinics that were in high crime areas to actually start some of the weapons detection, where if they're not metal detectors, they're kind of like if you go to Six Flags, you're starting to see these more and more. They may not be as visible when people are walking through them, but we've started to put these in our organization and we're rolling them out to all clinics. Response by local police and security, how fast is that? Do you have focus of security in-house? Is it true security? Is it police? What are they able to do? So some of the challenges in some of the non-hospital settings is the lack of security, the lack of technology that may interact with the main hospital. When you look at the community settings, they would maybe have to call local 911, and maybe in your settings, you may have to do the same. And then there's just a general lack of training. When you look at and what I had mentioned earlier, a lot of the folks that we're dealing with are in the high-risk clinic type settings, access clinic, orthopedic clinic, pain clinic. Those are the areas that we're finding that we have more of them and a more propensity for them. But knowing how to de-escalate them if you can, who do you call when you can? Do you have panic alarms? Is somebody close by able to respond? Active shooter drills, where do you go? How do you protect yourself in these situations? And then certainly when it comes down to the allocation of resources, how are you getting that information to the areas in the surrounding buildings for what people need to ensure that they're feeling safe coming to work every day? So local actions to protect our workforce here. We have a full court press, and this is part of our workplace violence plan that we have for 2024. But it shows that I run the workplace violence committee, which is this committee right here. It's been in existence since 2015 when I got here. We also continue to have meetings on high-risk patients. So now that we have a manager that works in this space 100% of the time focused on this issue, we have an ability to, and we've gotten the approval of our leaders, even as a safety net facility, to actually terminate patients from the system. Yes, we are a safety net. We have patient expectations of how they behave. And if they can't comply, even with warnings, and we've written several warning letters to let them know that on certain days you behave this way with certain people. And we give them warning letters because the whole goal is to really get them to reform their behavior and be respectful. Just as we would in any other situation. And if they can't do that, then there's alternative places for people to go. And many of the folks that we have looked to terminate have insurance to go elsewhere. They have just chosen to come here. So we provide this information all the way up to our executive leaders as well as our board of managers. But we work in collaboration with many other folks in the organization, because really, if I'm coming to work today, safety, I have to start with safety first, and that's me. That means I have to have an ID badge on that people can see, and I'm here for a justified business purpose. And if I can't, if I see you and you don't have a badge, and I'm going to ask you, if you're here for a reason, where is your badge? Because it is part of our dress code. And I hope you don't sass back at me. We're here to make sure that everybody is safe, and it takes some professionalism to be able to do that. Then we also have focused workplace violence committees, like the emergency department, our correctional health setting. We have a jail, so with about 6,000 to 7,000 inmates, that violence in there is very different than what you would have here in the hospital or in a clinic setting. We've also really pulled in our advanced practice folks, because they're peppered in many different service lines, and they see a lot. And so we're helping them to talk about reporting and what they can do, and getting trained in de-escalation. Our ambulatory surgery center has our pain clinic in there. So, and I think that they do some GI stuff over there too. Hospital at home, senior house calls, that's one that we have a focus on right now as part of a goal for our 2024 Workplace Violence Committee, our plan. And then we work really closely with the nursing department too. But this is the structure that we have, and it shows the how much this information transcends up the line too. So again, we as I mentioned, we actually partner with our physical safety team. These are some of the weapons detection systems. So right now we're doing this with patients, and we have accumulated several weapons just in the few months that we have had these actually rolled out. As I said, we had a badge up campaign, and when it comes to actual cases of where we have investigated, we've sent well over 200 behavioral warning letters to folks. And again, we have had folks that have said, you know what, and it's not just patients, but it's visitors too. We have had visitors and patients say, when I come here, I do need to be more respectful. That is really what we want. We want to be able to treat them and get them the care that they truly need and deserve. But we have also, when we look at the modification of services, this is where we put patients through, or the cases through, we call it a Preserving the Environment of Care Committee, where we will modify services. Meaning, if we can prevent them from coming into an inpatient setting, into a clinic, and we can send them their prescriptions through mail order, we're going to do that. If we can do a virtual visit, we're going to do that. And so we have opted with the approval of our executive leadership to be able to, and if they don't behave, and we escalated up the chain, take them through this committee, and if and once we deliberate from the committee, we move it to the chief medical officer, who will either support the termination or deny it and give us some pushback and tell us we need to work a little bit harder. But year to date, we've terminated 21 patients. But we also have the ability in the final termination letter, we let them know that should they have an emergency medical condition, they can always come back to us through the emergency department and they will get treated. But we also put termination screens up when a patient does come back through the emergency department to let people know that this patient has been terminated. It's an expedited treat. If they need to be admitted, we have a safety team that actually manages their care in an expedited manner. We're not going to push them out the door. We're going to make sure that they get the care that they need, but it's very concentrated. And if they don't need to be here, and we will treat and release appropriately after they've been stabilized. So we have a process for that, and it takes a lot of work. But some of these cases, and as we get into the case reviews, we'll see that sometimes we're the issue. You know, if a patient comes, has to hop 3 buses to be able to get here for a scheduled appointment, and nobody called her and told her that her appointment was canceled, we own that. I would be ticked off too. So we have to kind of think about what is from the whole view, where did things fall off, the wheels fall off, and where we got to get back on track. So strategies to address violence, looking at a complete risk assessment, and then developing and prioritize some of the methodologies. So remote monitoring if you need it, training on detection and prevention. So having somebody come in and do this from a third-party perspective if you don't have folks to do this in your organization. Looking at security technology. And now that the state of Texas has, the whole state has bought into and supported this bill, security people are coming out in droves. Every new system that's out there, so being very careful and don't being the earliest adopters, but really working with IT people who are watching, at least we're working with them, because they're watching the research and development of many of these companies that may be fly by night. And then looking at random audits to ensure sustainability once you have put new methodologies in place. You have to report these events. It takes time, but again, as I mentioned in the beginning, we can't fix what we don't know. So likely, if you work in an organization, they probably have some type of an event reporting system. They may have a hotline, you know, to be able to call things in, because we know that you're very busy. And then if you have a hotline, giving them the minimal information, like typically the patient name and the medical record number is really what you need. And then documenting this information in the medical record. Yes, with the CARES Act, people can get information from in their record, but you know what? If we have a trend of what we're seeing in documentation of unwanted behavior, that allows us to take cases forward to be able to investigate them further. And we look at police reports, we look at incident reports, we look at documentation in the medical record, even people that are inappropriate in my chart or on voicemails, we save that as collateral evidence to build our case. And so it all starts with an event report in the system. Looking at injuries. Where are people getting injured? Typically, it's above the waist soft tissue injuries when they're trying to protect themselves. But we monitor those and we work with our workers' compensation folks to identify where we have opportunity. We know that people year 1 in our organization, first year of work, are 3 times more likely to be injured than any other year, but it's followed by year 2, 3, 4, and 5. And they are sustaining soft tissue injuries. Usually, again, like I had mentioned, elbows, arms, and we've had some more significant injuries like orbital fractures when people have gotten hit in the head. We also have taken cases where there's been employee injuries through a root cause analysis, and our cases go up through the board. So that way there's transparency that they can see that this is a real thing. We don't just manage patient safety cases, we also manage and investigate the employee safety cases as well. And so when you look at actually prioritizing, you know, a risk assessment as an example, this is just a 9-box way that it's actually the safer matrix that's been developed by the Joint Commission. But if you are in this high box right here, it means that you see this often and there's a high risk to it. If you see that you're in this low area, you don't see it often and you don't see a high number of them. So it kind of gives you an idea. Then when you would go to put an action plan together, you would want to really focus on especially these items right here in the red. And then track them over time through your committee structure as to how well you are closing the gaps on those things. So some of the things that we have done in our record is STAMP is actually an aggression tool, a violence assessment tool that for folks that are typically coming in the emergency department. We are actually implementing a pilot in a clinic setting here, 2 clinic settings where we know that we have our high number of people coming in. But it actually looks at the 5 items there of what STAMP stands for. steering tone, anxiety, mumbling, and pacing. And if they stamp positive, it's either a yes or no. Stamping positive will show up orange on the medical record. And then that information from the ED gets translated into the handoff report when the patient is admitted to an inpatient unit. And then we put the safety sign of the hand on the door. It's an agnostic sign. My understanding when it comes for violence, you may see a hand with a heart in it as a national symbol. I didn't really realize that, but we created this internally because what we've identified is 50% of our employees do not have access to the medical record. Phlebotomy, nutrition. If I were to walk up into a patient room, I'm not going to necessarily be in the medical record. I'm going to walk into a room and I'm going to want to know that somebody has a propensity for violence, and I need to A, find out what's going on, or B, get a partner. So these are things that we've initiated within our organization that have helped quite a bit in protecting all of our team members, not just the clinicians. And then we just initiated a Brissett violence checklist in the inpatient psych area. Again, a standardized tool that identifies if they are high risk, then there's interventions that go along with that patient being high risk. And we just started this on March 27th. These are some of the flags that we've put out as well. When it comes to behavioral alerts, if patients are known to be inappropriate, we actually put alerts in so anybody can see that the behavioral alert, and then it will tell you what to do. When it comes to terminated patients, it will come up in black, and it will tell them that we do have to follow EMTALA, and and these are the elements of what's required to do. Some of the feedback we had gotten from the clinics was when patients were scheduled in the clinic and they knew when patients were coming in that were scheduled that were COVID positive, they would be in a different color. So we're actually doing the same thing based on feedback from the clinic folks to say, hey, if you guys know that patients have behavioral flags or are have a violent warning, we want to know on the schedule so that we can protect everybody. So that's one of the things that we're doing with the clinic. Questions before I move into case studies? Looking at time here. Anyway, so first one. So what's behind the aggression? So this is a male patient in his early 40s who's well known to the health system with a long medical history, including chronic pain. He has a psych history, including depression, anxiety, insomnia, and he had a recent tox screen. So he has several documented incidents of reported violence and aggression within 12 months. On a recent presentation to the clinic for a scheduled appointment, he had outbursts of behavior when encountering clinical staff. Police were called to intervene. He was escorted out once determined to be stable. For the background for him, he has verbal aggression towards staff. He's refusing to provide identifiers for check-in where they were unable to de-escalate him. On November 17th, he had verbal aggression towards a greeter and a nurse manager. So police were called and he had a behavioral alert placed in his electronic record. On 12/14, he had a MyChart message received from family formally naming clinic staff members, which really freaked them out, knowing that the patient knew their first and last name, especially when we just have first names on their badge. Police were present for a scheduled appointment. He escalated, police intervened, and they escorted him from the building. So in the assessment, we took him to the Preserving the Environment and Care Committee to review his case. We looked at the consults. We looked from an objective manner as to what's causing his physical ailments. So he did have chronic pain. He had from a psychiatry perspective, he had depression, anxiety, and insomnia. And from a palliative medicine perspective, he had refractory pain regarding his pancreatitis. He did have a positive relationship with his palliative medicine provider. But we also learned as we go to look at these cases, we can't just look at the physical components. We have to look at the trauma history. And so his trauma history started as a child. His mother was divorced. She had several boyfriends. And unfortunately, he endured a lot of sexual abuse by the mother's boyfriends. There's a lot of family abuse, and he had a depressive disorder and post-traumatic stress disorder and anxiety. And so we wanted to terminate him, but when we realized that when it came to the sexual abuse by his family members, he would encounter nurses when he would come into the clinic, and his mother was a nurse. So the nurse title, the nurse person was triggering him with his behavior. So we don't always see what's behind the aggression. So we made a recommendation, and this is what the chief medical officer provided back to us. So we put him on a behavioral management plan, and he had to have 0 outbursts towards staff in 12 months. And we would reevaluate him at 6 months. We also had to do a care plan with trauma and care for the clinic staff so that they could understand that sometimes the behaviors are for something much deeper, although we can't see them. And so they went through that training, and it was like an aha moment light bulb. But we also learned to schedule him in a manner that where it was either like early in the morning, just before lunch, or end of day. So there was a lot less distractions that were going on. And so we then followed up with him just last month, a year later, and he's actually doing quite well. So sometimes it's not always what you see, although we're trying to defend ourselves. And it takes a lot of time and effort to be able to understand it from the holistic point of view, not just what we're seeing from the behavior. The next case actually is the one I kind of mentioned earlier, of a female in her late 20s who's known to the health system, and she had been here for OB and behavioral health. She had anger issues. She sees red. Unable to calm down. She's afraid that she'll hurt someone, and she had several appointments of escalated behavior due to scheduling issues, where staff were feared for their safety with the need to call the police. And so they did place a behavioral alert in her electronic record. So she was incorrectly scheduled, but showed for an appointment resulting in yelling and threats. The patient was notified of the need for a pre-appointment testing, where she became verbally aggressive on the phone, and the patient arrived for her sonogram as originally scheduled, but the date was changed without notice. So again, this is a situation where we own some of this, where we should have been connecting with her and trying to do what we could to ensure that she was aware of the pre-appointment testing, but also the need for the change of the appointment. And so we looked at her information, we looked at her trauma history. And so we were to assign the patient to clinics, because there was a propensity for her to come in and hurt somebody, as I mentioned in the previous slide. If patients give us a threat that they are going to come in and kill somebody or shoot somebody, we move that into an automatic situation of that's a criminal offense. We take them very seriously. We're not going to sweep that under the carpet. I sit in an outbuilding from the hospital. We've had patients who we have sent termination letters to show up in our building looking for me. So we've had to, make some revisions and changes from the letters that we actually do. So we actually put her on a plan, and so the plan was denied by the CMO. She was terminated from the system. When we terminate from the system in that final letter, we give them 30 days to find a new provider and let them know that, yes, they can still come back for ED care only. But we also tell them we're not going to be tolerating the behavior anymore. So anyway, he denied the termination, or for this one, we owned it. And so he denied the termination and said that we need to do better by this. And the patient has actually done pretty well too. So when we look at the tiered process for managing patient aggression, this is basically what we do. We have behavior warning letters where we go through a lot of information. We put advisories out there about the alert that I had mentioned that had the lime green on the chart. We do the terminated case review, and it basically goes to our chief medical officer to either support or deny and push back on us. And then we do an annual year in review, just to make sure that patients either haven't come back, or if they have through the ED, that they've been more appropriate. And so some of the things I was asked about are available resources. So the Texas Hospital Association, Texas Nurses Association work together on a toolkit. The Joint Commission has a toolkit. the International Association of Healthcare and Security and Safety, these are like your police, your security folks. They're also driving a lot of this in collaboration with many other national organizations. And the American Society for Healthcare Risk Management also has a violence toolkit. But I think if you were to Google things, people would have, there's a lot of information out there. And I did testify in support of House Bill 240 and Senate Bill 240 last March, where this actually went through. I will tell you, Representative Click right here, she is a nurse. She had her arm broken. Representative Howard is another nurse out of the Houston area, I believe. She was the one who actually put the bill in. She's a nurse and had her nose broken when she was a nurse. So these are folks that were actually, and I think that he is an anesthesiologist. So we did have healthcare folks that were actually as part of the committee that really were intent on listening and very, very endearing to help move this bill forward. So on that, I will turn it over to you guys to see if you have any questions.